Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon, thanks for your company. In this programme we take a look at women's health, but before we begin, here's a quick word from Rural Health West's CEO, Belinda Bailey.
Hi everyone, I thought I'd just take this opportunity to let you know and give you an update about the Rural Health West Annual Doctor Service Awards. We held the awards again in March this year, and we're really proud to say that this is the 5th year that we've held these awards. And in those 5 years, we've recognised 160 rural doctors for their unending commitment to rural medicine in WA. This year we recognised 20 doctors who have contributed either 20 or 30 years of service to rural Western Australia. But in addition to that, we also recognised 4 very special rural doctors, 3 of them for either outstanding or extraordinary or clinically challenging medicine, and 1 who was a special award, which I'll tell you about in a moment. But our 3 special doctors were nominated by either their community or their colleagues for some pretty extraordinary medical practice. Dr Bernard Chapman from Mora, Dr Pascal Burton from Port Hedland, and Dr Philip House, many of you will know, who's an ophthalmologist who does outreach services, particularly in the goldfields. These 3 doctors were nominated by, as I said, community or colleagues, and were recognised by their peers at the awards ceremony, and it was an absolutely fantastic day. In addition, we recognised Emeritus Professor Max Camian, of many of you will know, and he was awarded a life membership of Rural Health West. The awards are sponsored by Wesfarmers, and our award recipients all get an award of $5,000, which enables them to do some continuing professional development. So we're very proud of the awards. It's a beautiful day, everyone feels fantastic, and we'd really love to encourage you to get online and keep an eye out for the time when you can nominate someone for next year's awards. I'd also like to just let you know, because you might not know, that Rural Health West is now in the business of recruiting nursing staff and allied health practitioners to country WA. We're focused on recruiting for the primary care setting, so if you have the need for a general practice nurse, why don't you come and give us a call and we'll see what we can do to help you.
Thanks, Belinda. Now let's get into the programme. Dr Olga Ward joins us and she talks to Dr Robyn Leake and Dr Susan Downs.
Robyn and Sue, welcome to the program.
Thank you very much.
Perhaps we could start with a topic that's caused a great deal of kerfuffle and angst, both for GPs and indeed for patients over the last couple of years, and that's menopause and hormone replacement. What's the real story on hormone replacement and the safety of it?
There's been a lot of conflicting data emerge, and it's no wonder that people are confused. Essentially, short-term use of hormone replacement therapy for symptomatic women is generally safe. The controversies arise, or the problems arise, with longer-term usage, and also in certain patient subgroups who may be at risk of some of the other risks of hormone replacement therapy. So by that I'm thinking of patients at risk of thromboembolic phenomena, and at particular cardiovascular risk, etc.
What about breast cancer, which is what the patients generally are really worried about?
Yep.
And I've heard quoted, oh, it doubles your risk. And then I saw one paper that says, well, your risk goes from 1 in 11 to 1 in 10.6. So what is the answer?
The answer is, firstly, I'd like to make the point that estrogen-only hormone replacement therapy has not been shown to increase the risk of breast cancer at all. And you may have heard recently there was a study that suggested that the risk of breast cancer with estrogen alone was actually lowered. The initial studies hinted that it might be lower, but it did not reach statistical significance. The most recent study did reach statistical significance. So that's the first piece of information that often gets lost in the data. With combined hormone replacement therapy, there is a small but real increased risk of breast cancer, which increases with the duration of use. The usual amount quoted is about 8 per 10,000 women. So it's a real increase, but it's actually quite small. And I individualise, you have to talk to every patient about that. And if you listen to the press, sometimes they make it sound as though you're compromising your life by taking this therapy, but you might have a better quality of life. And that is absolutely not the case for most patients.
So a small and measurable risk in some patients and individualised. How about you, Sue? You're a general practitioner. some women say life is not worth living without oestrogen. How do you manage your patients in a real life setting?
Well, you go through all the stats and things and what you think is happening at the moment. I think the women's study certainly did a great disservice to women because it frightened doctors and it frightened women, and lots of people just went off HRT and said, oh, we just can't do it. Either the doctors wouldn't prescribe it and the women couldn't get it. And then following on from that, because people weren't picking up scripts for HRT, the companies that make it couldn't afford to put it through the PBS system, and then a lot of it went off the PBS. So the people that actually needed it more were then still can't get it because it's now costing too much, because a lot of the people were getting it through PBS healthcare cards, etc. And once that was off, to put it onto full price, and now it is quite expensive. There's far less choice of what you've got.
You can still get a few preparations on the PBS.
You can get some. Patches they are adding more to, but the other ones, you know, all the little Cliogest and Cliovance and all those very easy ones to use have gone.
They've all gone. So patients are now claiming those back through their private insurance if they have ancillary, and otherwise not at all.
That's true, but a lot of the people that really needed it have low incomes and have not got those facilities to do it. But a lot of people find, you know, that, oh, I'm frightened, whatever. So you can try the other therapies like the red clover and the black oshkosh and whatever. There's been heaps of clinical trials on those, and nothing ever comes out as actually working perfectly in a double-blind trial. But just from general, my own experience, and I don't know about yours, people find red clover at least gives them relief of some of the flushes, better sleeps and things for a few months to get them over that period. And whether that's just a placebo effect, I'm not sure. But certainly
you have to bear in mind the placebo effect in HRT is worth 30%.
Yes.
So it's actually quite...
As everything else,
It's quite powerful.
Are there any other kinds of drugs that maybe we could look at using for these patients that are PBS prescribable?
Specifically for hot flushes, there are a number of non-hormonal drug therapies that are available. SSRIs have been widely used.
Particularly Effexor.
Yeah, the most commonly studied one is venlafaxine, but it's probably a class effect. The other options are clonidine, which has been around for donkey's years. Main side effect is drowsiness, but that's a safe drug and it's available. And the other one of interest is gabapentin, which is not on the PBS for this indication.
Yes, it costs a fortune.
Quite expensive, has the side effect in a lot of patients of making them drowsy initially, but they do tend to overcome that side effect. Interestingly, the long-term data with gabapentin isn't there. It tends to, the data suggests that the effectiveness of gabapentin wears off after, I think from memory, 4 to 6 months, which is interesting.
And I think the same with red clover as well. Just anecdotally, just I don't really know. I haven't got any details.
I think just about every one of those other preparations that my patients have tried over the years, they say, oh, you know, it was pretty good for the first few months. And then it kind of tailed off. And then they tried another alternative, and but I guess at least that gives them 6 months at a time, even if they're chopping and changing. What happens to the women who are over 60 and in some cases over 70, still getting disabling hot flushes every time they take themselves off their HRT, can't function properly without their oestrogen? Are you pragmatic about prescribing them oestrogen and letting them take the risks?
Yep, I mean the main risks that increase with age are of clotting phenomena, but with estrogens generally, it's specifically when you first commence them. So if you've got a patient who's been on estrogens long term and is otherwise in good health, although the risk goes up because she's ageing, the main risk with estrogen is when you first introduce it. There is an increased risk of stroke. Again, that goes up with ageing as well. But if you've got a fit, non-smoking, lady with no cardiovascular risks really, who's in that situation of having poor quality of life, I'd certainly prescribe it, continue to prescribe it. I wouldn't prescribe it for the first time to someone in their 70s, but certainly a continuity I think is reasonable.
Yeah. For those women who are on combined HRT, sometimes they would like to have a patch or something that's transcutaneous, or some of them would just love to simply use the Sandrina, the oestrogen gel or something. What happens if they can't make the patch stick on their bum and there aren't any other alternatives? You know, what sort of alternatives have we got for progestogens?
The difficulty has been with the cutaneous absorption thereof, which is one of the reasons why the combined patches came out so much later than the oestrogen-only patches. We don't have a reliably absorbed cutaneous preparation for progesterone. If patients want an alternative that's of reasonably long duration, then a Mirena is an excellent choice. Mirena lasts for 5 years and provides beautiful cover for the endometrium. It's not been studied in the context of HRT, but we know that it provides protection in premenopausal women, so there's no reason why it wouldn't provide protection postmenopausally with the lower oestrogen levels. So a Mirena is definitely a choice for someone who wishes to avoid systemic progesterone.
Yeah.
It also gives that just immediately post-menopausal or menopausal or perimenopausal time, gives you contraception.
Yep, and control of
and
menorrhagia.
bleeding control, which is very nice. What about the progesterone creams that came on the market again with a great deal of fanfare, which are, you know, supposedly progesterone creams, and to a lesser extent from the same group of companies, testosterone creams marketed for postmenopausal women. Do they provide any kind of reliable or measurable absorption? And will they provide endometrial protection?
Absolutely not. They should not be relied upon for endometrial protection. They've not been studied in that context, and the measurable absorption is argued, but it's probably minimal. Certainly with the YAM creams that came out a few years ago, the progesterone levels in the serum were found to go up by nothing. In fact, the only thing that went up slightly was oestrogen. So definitely not protective of the endometrium and should not be used for that purpose.
Can you actually measure a level of progesterone and say to a woman, this is protective? Like, I'm thinking, because everything's so individual.
Not really. We're not particularly good at measuring the artificial progestogens in serum. However, long-term usage of hydroxyprogesterone acetate and some of the older preparations, we know what is endometrially protective. It's been documented well in the past, and so we cannot say to women this much is progesterone is protective of the endometrium for those agents that are the long-standing synthetic progestogens.
Yeah. And you could actually keep going for a woman with, say, her Depo-Provera or even an Implanon rather than a Mirena to give them some progesterone.
The trouble with Depo-Provera is it's rather attacking her with a sledgehammer. It's a rather hefty dose.
It's a pretty hefty dose. But
and I'd be worried about osteoporosis and osteopenia in the postmenopausal age group. Also, the progesterones have adverse effect on lipid profile and in some women their blood sugar control, so I'd probably not be that heavy-handed. It's theoretically possible to do that, but I think if we could get away with a lesser dose.
What about testosterone creams? Or testosterone in general? Where does that fit in with hormone replacement?
That's, again, another very controversial area. Most proponents of the use of hormone replacement therapy would suggest that one should not be supplying testosterone to a patient in the absence of oestrogen and progesterone to get what symptomatic relief we can using...
As in additional oestrogen and progesterone on top of what they're not very much producing in
That's
their
exactly
ovaries.
right, yeah. Then if their symptoms are not controlled by those two well-studied hormones, in some cases it may be appropriate to add some supplemental testosterone. The argument for that being that some patients have measurably lower than normal testosterone levels, bearing in mind, of course, that it is normal to have a low testosterone at the menopause. It's not actually a disease state. The arguments for it, some people find their energy levels are a little better. Some people find it perks up their libido a little. I must say personally I haven't had a lot of people like it very much.
And also the levels don't necessarily correlate with the symptoms, do they?
No, and that's indeed correct. Yep. And people vary a large amount in what they're able to absorb through the skin, as with all of our cutaneous medications. So I use it occasionally, rarely, and I have to say with limited success in terms of the resolution of symptoms.
Yeah.
I guess because the libido is such a multifactorial.
Yeah, and does either of you have any magic cures for the complete loss of libido that many women complain of at the menopause?
I usually suggest that they have a read of Rosie King's
Yes,
excellent book,
yeah.
Where's My Libido? Because it talks about...
And the other one, Great Loving Good Sex.
Yes,
or-
that's her first one, yeah. About the fact that libido in women is so multifactorial. If it was a matter of apply testosterone here, wouldn't that be great? We could all do that. But in reality, it's not as simple for women. And getting women to understand that, I think, is half the battle. Getting their fella to understand that is 3/4 of the battle. And so I usually recommend an approach of educating the patients. If there's any local issues that need to be addressed, dyspareunia due to atrophy, for example, well, sure, treat that. There's nothing that squashes libido more than pain.
Yeah.
But I think it's pretty uncommon for just hormonal therapy to be the answer. I think that's pretty rare. Would you agree?
I agree. And what about the place of DHEA?
Again, controversial. DHEA is very rapidly metabolised in the body to testosterone and oestrogen. It doesn't hang around as an intact compound for very long. Some people even argue that it has any role at all as an intact molecule. Some people argue that it does. It is controversial, and I certainly don't prescribe it as an agent myself.
Well, I know some of our Indigenous patients use bush medicine to treat their menopause symptoms, and I'm presuming that Indigenous women, even living a traditional lifestyle, are still also getting quite a lot of menopause symptoms. We don't often hear them talking about it. Should we be asking? Is it a taboo subject?
Yes, women can ask women about anything about women's business. Female doctors can ask women. They don't often admit to specific things. Usually it's urinary incontinence that you get a thing from, not necessarily flushes. And it's more what we find when you do a pap smear or whatever, and it's very atrophic, and you ask them direct things, does sex hurt or whatever, and then they might come out with something. But they don't talk about flushes or night sweats or things crawling on them or anything like Caucasian women do quite readily. It's something, and also they seem to have, and this is anecdotal again, they seem to have children and then tend to have early menopause or not bothered greatly by menstrual things. It's not in their psyche to know when their last period was, or just doesn't come for them.
Yeah. What's your experience, Robyn?
I think I agree. People don't complain of a lot of hot flushes, and the ladies that I have asked, not really.
No.
And a lot of the Aboriginal ladies that I see seem to suffer from less of the menopausal dramas that other ladies, far less prolapse, for example, even though they have, often on average more babies. I think perhaps having them younger.
Yes.
And quite possibly there's a genetic component to their connective tissue that just protects them against so much prolapse, but certainly I think less common in Indigenous women. Urogenital atrophy and pelvic floor dysfunctions, of course, not unheard of. And that's something that sometimes people volunteer, but often you have to ask.
Yes.
Yeah. Well, from menopause to contraception, the biggest single problem with Implanon seems to be uncontrollable bleeding, or at least unpredictable bleeding, which can sometimes be really, really severe. The ladies often love it for the reliability of the contraception. What can we do without taking the Implanon out?
Again, there's been lots of people try lots of things, and basically you can try to add some oestrogen for a short time, 3 weeks or so, via the combined oral contraceptive pill or an oestrogen patch for once a week for 3 weeks, or some oral oestrogen a day. And there are some other things that people have tried, doxycycline for for 5 days.
Now, doxycycline, being an antibiotic, seems like an odd kind of choice. What does it do?
Well, Robyn.
We think that it stabilises the endometrium. It's not used as an antibacterial in this context. There's some characteristic that it has, that it's an endometrial stabiliser, and that's the problem with Implanon. The endometrium becomes thin, but not just thin and fragile, and it's the fragility that's the problem. And oestrogen allows restoration of that fragility.
And really, in 5 days, and you can make a difference with the doxycycline? Like, you don't have to go for a couple of months or a month or anything?
No, it's short term.
And how long does it stabilise for?
That's a very good question. I don't think anyone really knows.
And it works brilliantly for some people and not for others.
Yeah.
You've got a few other choices. The other is tranexamic acid and mefenamic acid.
Which cyclocapron, really, isn't it?
Yep.
So, again,
And
looking at
Ponstar.
just to stabilise fragile bleeding epithelium.
That's right.
It's similar to when you're using it for bowel cancers or lung cancers.
Yep.
Do you think it works?
It's suck it and see, really. It does work for some people, but not for everybody.
Yeah, because they're enormous tablets and you've got to take them, again, just a couple of days?
Yeah, I
5 days.
Yeah, I wouldn't be
5
taking
days?
them long term, no.
No.
Any other options that you've tried or that your patients have tried that you've thought have been really good?
There's some data also to suggest that using the mini pill, again, not for further thinning of the endometrium, but for a slightly stabilising effect. So by that I mean a progesterone-only pill can be used. And I've certainly done that with some success in some patients.
For how long?
I think I used it for a month and then stopped, and they knew that it was perfectly safe to resume if the bleeding began again. So that's another one you can try.
Yeah.
And that has been studied.
Do you find that it's the 3rd year of the Implanon when these patients are getting the problem, or just, you know, when they first had it put in?
Beginning.
It's mostly the beginning.
Mostly at the beginning, just trying to settle it down. Is there any time when spot bleeding on Implanon kind of raises red flags for you?
Yes. I think you've got to treat it, I mean, especially if they've had a period of no bleeding and then they suddenly start getting bleeding again. That always worries me, and then I check them for chlamydia and gonorrhea PCR swabs, and also pap smears, and sometimes endometrial papels I use out in the desert. Yeah, you've still got to think, could this be something else? I don't think you can just blame the Implanon, especially if there's been a period of amenorrhea.
I agree.
Yeah.
Thanks to Dr Hadlow for taking the time to speak to us. Now let's return to the discussion with Olga Ward, Dr Susan Downs and Dr Robyn Leake.
Now, could we talk about adolescents, who are not really just young adults, are they? They come with their own sets of problems. Are there anything specific that you see in young adolescents, and I guess particularly for all of us, young adolescent Indigenous women?
Well, I deal with a lot of young Indigenous women. In fact, hardly any young Caucasian women these days. Mm-hmm. Certainly there is a lot of sex at a very early age than my previous experience with Caucasian women. There's an idea that we can fix it anyway, that we've got, you know, people are screening them all the time, and they present for screening, and then they have a zap pack and it's all gone. My big thing... So
the prevention isn't very high on their list, or protection isn't very high on their list, because they can just go to the doctor and get some pills and make it better? Is that...
I think that that's sometimes the case, because whilst you can ask them to use condoms, their chance of them actually having condoms or their partner having condoms at the time isn't very often, from my experience. Or it can be fine for a week, and then there'll be other encounters where no condoms will be used. Yeah. My biggest thrust that I do with them is saying, sure, we can fix it, but the more infections that you have, the more time you've got bugs into your tubes, the greater chance you're going to have of infertility, and when you want to have a baby, there's going to be problems. And certainly we see that a lot in the Aboriginal population. Mm-hmm. There seems to be a primary fertility, which is usually due to frequency of STIs, and then there's a secondary infertility. They often have a few babies very quickly, and then then can't have babies for quite a while. One of the things I've noticed in my group, which are Matu in the Western Desert, Eastern Pilbara, is that the men go through stages of subincision due to their law. And so they might start at 12 or 13 having a nick at the base of the tip of the penis, and then gradually over years it gets extended. So by the time they get to 30 or 40, 35, they might have a new partner that's had babies with somebody else prior, and then their own partner they've kept for that time, and suddenly they're wanting more babies and can't have it because the ejaculate is not getting where it needs to be. One of my things that I've been doing with them is to actually ask them to use condoms with the tip cut off so that the ejaculate gets into the right place. And we've had quite a number of good pregnancies following a secondary infertility because of that cause.
Yeah, well, it's something we might not think about asking every day.
So now with my groups, and it's mostly in the Pilbara and the southern Kimberley, subincision can be a major thing. And I ask them every time. I draw pictures. Sometimes it's shame, you know, they say, well, can't talk about men's stuff. But I've actually had a few men come in and show me, which has been a major, major step into that cultural women's business, men's business stuff.
And I guess we can always discuss with our male colleagues to check, because again, that's not something that you check on a routine basis. Robyn, what's your experience with your adolescent patients?
I agree with the Indigenous lasses. Contraception is something that we chat about. Unfortunately, I believe unfortunately for a lot of the young lasses, what their partner feels about contraception is of paramount importance, and there are sometimes some barriers to the uptake of hormonal contraception because of real or perceived barriers from the male viewpoint. You know, the partner doesn't want them to use it. Compliance can be a problem with anything that's needed daily.
Yes.
And the other, I agree, there's a huge number of patients who come in with recurrent chlamydia or gonorrhea and have troubles with fertility.
And even Implanon, often the male partners don't like their female partners to have Implanon in, because it is perceived by them that this is slut stick, as they've called it, that it gives the female chance to be promiscuous, and also that other males know that they're infertile.
I've come across a couple of patients who've asked if they can not have the Implanon put in, and in the usual spot in their arm.
Oh, really?
Because they don't want partners, or they don't want people to know that they've got it there. And that's mighty difficult for me. How would you deal with that?
Have you come across that?
I've never, but it's a very interesting thought.
And I have heard of some doctors have put it in the thigh.
I was actually chatting with a UK patient the other day, a young woman of 19, and she mentioned in the UK that one doesn't get a first pap smear until one is 25. She was quite surprised that she'd been offered one at the age of not quite 20, having been sexually active since she was 14. How does the UK guideline of 25 and the Australian recommendation of as soon as you start having sex, how do they marry up?
It's all about cost-benefit analysis. If you look at for example, the increased rate of detection doing yearly pap smears versus 2 yearly, it's 99 versus 98. And so Australia said, well, 99, 98, 98 is pretty good. We'll go with that. In the UK, they've decided that most young women will have exposure to HPV when they become sexually active, and it's not until that HPV has been on their transformation zone, not eradicated, and then creating dysplasia, that you're likely to run into to problems with invasive malignancy. So again, the cost-benefit analysis suggests that 25 is an okay time to start. However, we've all got anecdotes of patients coming in with certainly adenocarcinoma before age 25. So it's whenever you've had that personal experience, it's a little bit hard to swallow the 25 years of age recommendation. I have heard rumours that they're thinking about doing that here in Australia, but it hasn't come to fruition as yet.
Again, maybe the bureaucrats are feeling safer because they've vaccinated all the girls. Sue, what's your experience?
My rules that I learnt were that if you've been sexually active for a year with multiple partners, then you should be doing a pap smear after a year, or 2 years if it's just been one partner or so. And I guess I've continued to use that. But I have heard from some gynecologists that because we're doing with very young children or young girls that are sexually active at 13, 12, whatever, and with multiple partners, they're going to pick up the HPV, but a lot of those lesions that are just going to be self-healing, and that you're going to be treating a lot of people with colposcopy and LETs and things when they would have just reverted to normal anyway over some time. And you don't want to both have to ask people to come and have those tests, which are yet more invasive than pap smears. And when things are just going to settle down their own good time anyway, there will always be some that don't. But to be doing pap smears on 13-year-olds and 15-year-olds is probably not what we should be doing. Do you agree?
That's absolutely correct. And most young women who are immunocompetent will rid themselves of HPV and even dysplasia.
Yes.
So I was looking at a study that King Edward had done from their adolescent clinic. I think an unpublished collection of data, but they were looking at low-grade and high-grade abnormalities that they were seeing in the adolescent clinic, and there really was quite a high proportion of high-grade abnormalities. I'd feel a little uncomfortable just kind of leaving that and monitoring it.
Well, we often monitor, we do a colposcopy, but if you see a lady with a young lass with a CIN2, for example, that's quite small, I quite frequently just watch them. But they're having colposcopy watching, not 2 yearly pap smear watching, which is a different kettle of fish entirely.
I must admit that occasionally I'll see somebody with a CIN2, and it's such a small area, as you say. You take the biopsy from the abnormal area, you've just about removed the whole CIN2 bit from the cervix, and I think that very brisk healing that they get after that often stimulates the immune system into killing it off. which is very helpful. So where are we at with HPV?
I certainly think I've seen way less warts, genital warts, through my clinic since the advent of the vaccination, which is not the primary aim of the vaccine after all, because warts are inconvenient.
It's against a completely different subtype, isn't it?
Yeah, that's right.
But
I agree with you. I don't see nearly so many patients with it.
And but I still think there's plenty of dysplasia out there. I don't think it's been around for long enough to make too much of a difference. I chock-a-block with high grades in my practice.
But the HPV that causes warts is not the ones that cause cancer?
No, some number 6 and 11, but the quadrivalent vaccine covered that.
Yes.
But the bivalent one does not, yeah. But I still think there's plenty of dysplasia out there. Would you think you're seeing the same number of abnormal smears in general practice? Or?
I think I am seeing the same number, yeah.
Yeah.
So
I had a little kind of downturn when the Gardasil came in for about 3 or 4 years. I would be seeing, you know, one minor abnormality every 6 months, and I thought, oh, I should give up colposcopy. And then, of course, the minute you think, oh, I'll just throw in my colposcope, in come 5 in a week, and you think, oh, okay, maybe it's just a statistical blip. Could you, Robyn, maybe talk us through the current guidelines for colposcopy and managing abnormal pap smears in younger women and in older women?
Yep. So in the youngsters, a young lassie has a low-grade abnormality on pap smear in the absence of symptoms that are concerning, such as post-coital bleeding or intermenstrual bleeding. So your average fit, healthy young thing who's got a possible low-grade or a definite low-grade on pap smear is offered a repeat pap smear in 12 months. At that 12-month mark, if things are the same, she can then be offered another pap smear in another 12 months, or offered a colposcopy if she wants. I think if you have 3 in a row, pretty much you should offer colp. And at colposcopy, if we confirm a low-grade lesion, whether just visually or with a biopsy, that patient is then referred back to the general practitioner for 12-monthly pap smears. And this is the thing that always catches people out. If that next pap smear is another low-grade change, she does not need another colposcopy. The advice at the bottom of the path form, the result, they don't know who's had a colp and who hasn't. So they will write, in view of ongoing low-grade change, colposcopy suggested. You don't have to do that. If you've already referred her for the colp, that's good enough. Because it's so often I see people bouncing back that I've given up. Well, I haven't given up. As well as telling the GPs they don't need to refer them back immediately, I tell the patient, if you have another same low-grade change and your GP tries to send you back for another colp, say, no, I don't need to, I've already done that. Because you get lots of people bouncing back who really don't need it. And as long as they
I always find that really interesting, because I've quite often sent them a whole screen of information on the pathology form, including the colposcopy findings. But I think it's just an automated response
That's
that,
right.
that the lab produces.
But you don't have to have an automated response to that response. You can say, no, I've sent this patient off.
So you can actually ignore it.
Yep. Obviously, if it's a high-grade abnormality, it's a totally different kettle of fish, and they need to be managed according to whatever they are. And that may be watchful surveillance in the case of a fit young lady with a high-grade change. It may be completely appropriate to just watch her, but she needs to be watched closely with colposcopy.
Yeah. And what about older women? Slightly older women. I mean, they say older women, and it's kind of over 35.
Yeah. So
now that I'm well and truly over 35, they look like younger women to me.
When you get to that threshold of ancientness, which is 30, the recommendations change. If a woman's had a first low-grade abnormality and hasn't had a normal smear for, I think it's 2 years, they can be offered colp straight away. If your patient is a regular attender and she's over 30 and it's her first low-grade smear, you're well within your rights to just repeat that in a year. I think if there's 2 abnormals in a row, again, colposcopy is recommended. None of this applies to a high-grade smear. None of this applies to a possible high-grade smear. None of this applies to glandular abnormalities, whether atypia or ACIS or frank.
So anything glandular just goes straight to the colp and straight to the specialist.
Yep, and usually that's what pathologists will recommend, but every now and then they do slip up. So you need to know.
And what about HPV testing at the same time?
Yep. At the moment it is not recommended because it doesn't change anything. So whether a patient has a low risk or a high risk HPV, if her pap smear finding is just atypia, doesn't matter what kind of HPV it is, it's not going to change a thing. And so it's not recommended that you do that at the moment. It just incurs greater cost to no change in
It's
therapy.
only if there's a high-grade lesion, isn't it? Or if they've had a high-grade lesion.
For follow-up. So
follow-up,
follow-up
yeah.
of treated high-grade lesions. Having said that, I do occasionally do it, offer it to ladies you get the occasional woman, and usually they're in middle age, and they've had low-grade smears times 10, 15, every year ad infinitum. They've had colks every 2 or 3 years. And you say, right, why don't we just do an HPV serotype for you? Because if it's low risk or negative, I'm really going to refrain from doing any more colposcopies. You can just keep. So very occasionally, in a very special circumstance, it might change your management. But if you're just doing HPV because you can, at the moment, our guidelines don't support that action. In America they do, but not here.
Well, that's good to know. Are Aboriginal women more at risk of cervical cancer because of their community subtypes of HPV, or are they more at risk for other social factors?
Other. I think they're more at risk due to non-participation in screening rather than anything else. They do have a poorer prognosis too when they do develop malignancies, again probably because of later diagnosis.
Yeah.
And even when you've screened them and you've got the report, actually
In front of you.
the time limit of finding them and getting them successfully to a place for colposcopy, the time limit is also delayed.
Yeah.
So it's one thing is doing the pap smear, and the other thing is getting follow-up.
Yep, I agree. A lot of the population are very mobile.
Very, very
By
mobile.
the time you've done the smear and got the
Yeah.
result, they're in another town 500 k's away.
And then actually physically getting them to the appointment at the right place at the right time on the right day adds different stresses.
And no telephone and go and walk about and gone for a funeral and
All
Absolutely.
those.
All of the above.
So very, very difficult. Are genital warts an actual indicator of cervical pathology, or are they just a coincidental yuck factor?
You can have those low-risk subtypes, so serotype 6 and 11, that cause the external warts. You can have those on the cervix, and you can have quite frondy, interesting-looking ones on the cervix, but they're of no more importance as a precursor to high-risk dysplasia and malignancy on the cervix than they are on the vulva. That's not the subtype that does that. However, of course, you can have a lucky and unlucky individual who has more than one serotype, and that's something that's one always needs to bear in mind. I've certainly had a few patients with warts on the outside, and I go, you'll be right, love, the cervix will be fine. You look in, not. So you have to bear in mind that just like you can get chlamydia and gono together, you can get HPV 6 and 16 together.
Yeah. If they do have fronty warts on the cervix, I mean, they are quite friable, and I would normally treat them just because they bleed. But how do you normally treat them?
Normally don't. Normally say they'll probably resolve when the external ones resolve. However, if they are symptomatic, and I agree with you, they're often frondy and bleed with intercourse, then just very gently diathermy them, not to the point of actually taking away cervical tissue as one would for, say, a CIN3 lesion, but just a superficial diathermy to try and get rid of it. And it also helps stimulate the immune system in a repair of destruction kind of way you might make that immune system boot the rest of the virus out as well.
Yeah.
How do you treat warts when you find it?
Externally?
Externally.
Tricky. I tend to use Aldara if they're in multiple locations, because you can imagine injecting local into all of those, how painful. I try and avoid that and use the Aldara. If they've got a cluster in one spot and they would prefer something destructive, I try and see if I can get all the local in one area. If they failed Aldara and they come back again, then sometimes I diathermy them under general anaesthetic if they're widespread. But I haven't had to do that for years.
I was going to say,
it's just, I don't know why, but it's coming down in frequency.
I haven't seen it a lot. It's certainly come down, but I have seen it recently. When I used to have access to dry ice, I used to put forceps into it, freeze the forceps, and then just pick up the wart with the forceps until they went totally white. And that wasn't greatly painful because it was the actual lesion that was getting frozen, not so much the surrounding skin. And that was very successful. But most places I go these days, we don't have that facility, and podophyllin and things is hopeless. So I try and go for Aldara, and most of the AMSs will provide that.
Yeah. I must admit I use liquid nitrogen sometimes for the localised things, but I like to use it on a cotton bud. I haven't thought about using the forceps.
The forceps are brilliant.
Idea.
Absolutely. Wait till the forceps go really frozen, pick it up, and
with gloves.
And it transfers. Yeah.
Does either of you have any final take-home comments for the doctors?
I would say to be vigilant in offering screening, and with regards hormone therapy, I think probably the most important for that is tailoring it to the individual patient. I don't think you can really make blanket rules.
And I think just at every consult you've got to think, you know, are these people sexually active? Think about contraception, think about chlamydia in particular, because it's absolutely out there. And then while you're doing the chlamydia, you do the gonorrhea and on a PCR swab. And whilst you don't want to over-screen people, I think that picking up those things is going to help in the long term as far as infertility and things, so that the instant things will have widespread things later.
Great. Well, thanks for joining us today.
Thank you.
Thank you.
Well, finally tonight, Jean Hales is an organisation dedicated to promoting women's health. Carolyn Wall, Coordinator of Health Professional Education at Jean Hales, spoke to us about the online resources available to support GPs in managing women's health.
Jean Hales for Women's Health is a national not-for-profit women's health organisation. We're based in Clayton, Victoria, and comprise a research unit, a medical centre and an education unit. We run various health professional activities from our site in Clayton. We have a national seminar program which does reach across to rural and remote Australia. We also provide a supervised clinical attachment program based in Clayton, and we have ad hoc health professional education sessions, a webcast program and online activities. We currently have 3 active learning modules on our website: prescribing hormone therapy, osteoporosis and diagnosis and management of PCOS. All of these topics take approximately 6.5 to 7 hours to complete each ALM. They're accredited with the RACGP with women's health points, and they're all with 40 Category 1 points. We have 14 webcasts also available on our website for people to view. These activities also attract points, and all of the activities available on our website are free of charge. Our clinical attachment program is run through our medical centre in Clayton. HPs and GPs are invited to apply to attend these sessions. Generally, it's a case of attending for 3 sessions with clinicians of your choosing. We have gynecologists, endocrinologists, women's health GPs, physiotherapists, and you sit in with those supervisors and complete an attachment. They take 10 hours to complete and also attract Category 1 points through the RACGP. For all of the activities I've spoken about today, you can contact myself at the Foundation, carolyn.wall@jeanhales.org.au, or our toll-free number, which is 1800-JEAN-HALES. Our website is www.jeanhales.org.au.
And thanks to Carolyn Wall, Dr Olga Ward and her guest for their time on the programme tonight. Now, if you'd like to consider further continuing professional development in women's health, Rural Health West has a number of programmes related specifically to this topic. They are Supervised Clinical Attachments in Obstetrics, GP Obstetric Mentoring Programme, and Obstetrics and Frontline Gynecology Workshops. Further information regarding all of these programmes can be found by visiting the Rural Health West website at ruralhealthwest.com.au. As well as those resources, you can also watch a special edition webcast of the Rural Doctors programme that continues this discussion on women's health. Visit us again at ruralhealthwest.com.au and follow the links to watch the programme. It's well worth the look. Rural Health West are also involved with a suite of courses at CTEC that might be of interest to you. Here's Olga Ward with more information.
Rural Health West proudly supports and indeed has major input to the design of a suite of courses for rural procedural GPs called the Cutting Edge Suite that covers everything from essential, very basic surgical skills, including suturing techniques, right up to advanced emergency procedures, advanced surgical procedures, and advanced skin procedures. The gynecological procedures course this year is being held on Wednesday the 27th of June 2012. This is a course with an eclectic grab bag of skills stations where doctors can revise pelvic anatomy on cadaveric specimens and have a look at some of the procedures that they may or may not do. It's suitable for GPs who do shared antenatal care. It's also suitable for GP obstetricians and GP surgeons who do caesarean sections. So we cover everything from playing around with a hysteroscope, even if you don't have a hysteroscope to play with, having a look at colposcopic procedures and LETS procedures to see what is happening to your patient when they go to the gynaecologist, looking at complications of caesarean section, including ureteric and bowel repairs, and looking at some procedures that are done in office gynaecology, like inserting and removing difficult IUDs, doing endometrial biopsies, marsupialising Bartholin's cysts. There's a considerable amount of discussion and demonstration of procedures such as the B. Lynch suture, which we hope we won't have to do for postpartum hemorrhage, and a considerable amount of practice in repairing vaginal tears and third-degree vaginorectal tears after delivery. We do realise that not all GPs do all of these procedures and not all GPs are involved in obstetrics, but it certainly gives you a good perspective on what might be happening to your patient and how to fix it in an emergency or in the unusual but certainly not unknown case where a patient comes in 10 centimetres dilated and wants to push, and you happen to be located in one of those little hospitals where the last baby was born in 1993. It's on Wednesday the 27th of June this year and it costs $650. It's also eligible for a rural procedural grant in general practice surgery and general practice obstetrics.
We'll be back on the 1st of May with a programme focusing on extreme temperature health hazards. In the meantime, from Jerry Gannon and all of us here at Rural Health West, thanks for joining us.